Wrapping up this edition of Sports Medicine Weekly on this Saturday morning. Nice long segment here of Ask the Doctor. I'm Steve Cashel with Dr. Brian Cole. Got some good questions for you, Doc. And again, if you want to be involved, folks, in our Ask the Doctor segment, you can go to the homepage of our website, sportsmedicineweekly.com. We give listeners the opportunity to have Dr. Cole address their specific sports injury issues. I've got one right here, Dr. Cole, from a young person named Ian asking this. Is it better for your body to run in the morning or at night? Do you have a theory on that?
So, Steve, it's a great question. Better to run in the morning or the night? I think, honestly, it depends. If you look at the science, one of the issues of running in the morning is that you've just slept 6 to 7 hours, your body temperature is down a bit, so it takes a bit longer to get going and sort of rev up, get loose, and so forth. So your what we call perceived exertion, you feel more stressed. You feel like the run, all things being equal, is much more difficult in the morning than if you've done it after you warmed up. So that's one of the challenges. The flip side is if you run in the morning is that it kind of basically just kickstarts your day. I don't know if you do that in the morning ever, but
I can't.
Your body's natural endorphins get going and so forth. So your energy generally tends to be higher after you've had some high-level exertional exercise in the morning. So that's one advantage of running in the morning, but it does often require a prolonged warm-up period. And you just, if you're not a huge runner and you're just trying to get in, you're going to like it a lot less in the morning than when you've been up for several hours.
See, I'd rather work out late afternoon and night. You're one of those guys that can roll out of bed and do a lot of your workouts are first thing, right? Well, basically because you want to get it in.
Yeah, I do it because it's a practical issue, because if I wait and I try to say, well, I'll just do it when I get home, umpteen things happen during the day. The one thing I know for sure is when I get out of bed, if I got up early enough, there's nothing else in my way except my exercise. You know what I mean? No one's going to take that away from me. But if I put it off, the chance of me doing it at night, or I get home, I want to see the kids, whatever. It's harder. It's very unpredictable at that juncture.
Do you eat before you work out in the morning?
No, I generally don't.
You jump out of bed and go to the basement?
I do. I'll have a workout drink that has some caffeine in it. I like that. Caffeine's
before
probably
you work out?
That's probably the best supplement you can take to get things going in moderation. Is if you say what's the number one performing enhancing drug, it's actually caffeine.
Wow.
I wouldn't call it a drug, but it has that effect.
What's your favorite morning workout?
I would, because I'm only doing it during the week, twice a week, I'm good. I like whole body, but I typically do core lower body or core upper body. I split it up.
Do you stretch before?
Yeah, I always do. So pre-workout activities that basically some type of dynamic activity that loosens you up and gets the blood flowing and so forth. And I think that prevents injury, and I think it makes your workouts more productive and you get easier for recovery as well. Some type of functional movement before you get going.
Isn't that the double-edged sword, though, the catch-22, where you don't stretch a cold muscle, but in order to work out, you need to...
Well, it's the thing that most trainers will do, for example, is they'll do some type of dynamic workout. You're not just sitting there stretching, the classic hamstring stretch, things like that. You do some light jogging, back and forth, sudden stops, starts, things like that. Walking lunges and rotational things and world's greatest stretch. There's all kinds of things that involve dynamic warm up where you're not just stretching a muscle in isolation. I think that's probably less common now.
How have you ever done box jumps?
I have. Yeah,
Are they good on the knees or bad on the knees?
I don't think it's bad. It's not bad on the knees. It's if you don't do it on some regular. I'll just tell you, as we get older, our muscles and tendons get less flexible, and box jump is what we call an eccentric load. You jump down, and your muscles have to contract to decelerate what you're doing. Does that make sense?
Yeah.
So let's say you jump off. If you didn't decelerate, you would collapse, right? In order to decelerate, your muscles have to contract and control your joints so you don't collapse.
Right.
So as we age, eccentric loads, which means the muscle contracts and lengthens at the same time. So figure out, like, if you're lifting up a dumbbell and you're letting it go, your arm, extend, right? At the same time, you're still contracting the muscle.
Sure.
Eccentric loads are a very common source of injury. So when you do a box jump and your muscles elongate and then try to contract at the same time, that's the very easy way to pull a muscle. So as a guy like me and you who doesn't do it all the time, when you're younger, you can tolerate a whole lot more. So I think box jumps are awesome because it's explosive and you work on what we call frontal chain and posterior chain, the front of your legs and the back of your legs at the same time. it's a complex exercise, so it's wonderful. But as an older person, if you don't do it on a regular basis, the concern is you strain a muscle.
Have you seen that with NBA players who maybe have suffered ACLs
hardly
because of doing lack of box jumps?
No, the other thing about box jumps is that it activates your glute medius, which is probably one of the most important muscles in preventing ACL injury. That's in your butt.
Okay.
It's like, it's a small muscle.
Gluteus maximus?
Yeah, well, that's your big muscle in your butt. So the smaller one is the glute medius, and that's the one that controls rotation of your hip, keeps your hip level, and it's one of the most important ones with a jump and land. That's the most important muscle for that purpose.
Okay. I mean, all right, so at my age, would you suggest box jumps? I've never done them.
I think eventually, but I would.
I'm thinking of a good cardio workout with box jumps.
It's very good. It's a complex exercise. It gets lots of muscles at the same time. But I would say that you'd be doing a 12-inch or a 6-inch. You're not going to do an 18 or a 36-inch box jump, for starters. And for those types of exercises, form is really important,
right?
So I think that people watch somebody, that looks great, I'm going to do some box jumps, I'm going to do some clean and jerks or Olympic lifting and things like that. That's how guys like you and I get hurt, because form is everything.
Okay, next question in our Ask the Doctor segment for Dr. Brian Cole. How can I determine if my daughter or female athlete is at risk for a serious knee injury? Can you determine that?
Yeah, you can. That's a good question. So, you could do something like a functional sports assessment, which is a series of 5 or 6 activities that look at known risk factors for ACL injury. So there's been some really good work in the NCAA looking at women athletes and the risk for ACL tears. So, for example, women tend to have very weak glute medius. Their hips tend to collapse. They tend to run or jump with lower flexion angles of the hip or the knee. They tend to do this with the foot turned out. They may have very strong quads and weak hamstrings. Those are things that are at risk for an ACL tear or a serious knee injury, which, those are the same thing. ACL and serious knee injury are the same thing. So there is a test. For example, we do it at Midwest Orthopedics where people can come in and they can do a functional assessment where we video them at these higher risk activities to see how they decompensate and see if there's side-to-side differences. So ACL prevention is a big deal, and it's been shown that it can reduce the incidence of ACL tears if you pick up on these risk factors by 30 to 35%. So it's really important.
Okay, our next Ask the Doctor question comes from our own producer, Shane, has a question about NSAIDs, non-steroidal anti-inflammatories, right, Shane?
Good job, Steve.
Thank you.
NSAID.
So tell me if I'm doing this the right way, or tell me if I'm doing it the wrong way. Should I be taking, if I've got a softball game or if I've got a dodgeball game, should I be taking preemptive ibuprofen or Advil, like I pop 4 before the game, or should I be popping 4 afterward? Should it be preemptive or reactionary?
Do you typically get sore after you play?
Yes, my throwing shoulder.
Yeah. Okay, your shoulder. So it's also another good question. And I would say that a reduced inflammatory response is one thing if you take the proper dose of Advil or Aleve, as well as just a pain mediator. So if you're not in pain, obviously in pain relief is your number one thing, then I'm not sure taking it before necessarily prevents the onset of pain, but I imagine it might. It might heighten the threshold for you to become painful. There's something called preemptive analgesia, which we would do in surgery, where we'll do blocks and things like that before we actually do the surgery itself, which have some data that shows that the postoperative discomfort is less. So there might be some advantage to doing it. The other thing is it might mute or dull your inflammatory response if you take it before you're highly active, which in theory could be a good thing. We're just not used to taking them typically in that way. And, it'd be interesting if you actually experimented. I don't think either way is bad for you, by the way, as long as you take it with food and you have no contraindications to taking them. It might be interesting for you to try,
both ways?
Yeah, both ways. I'd be really interested to know I haven't studied it, and I can't cite all the literature, and I bet there is literature on that topic. But intuitively, you could argue it could work either way. But when you don't have a painful condition yet, what are you really treating? And then you deal with the half-life of it, which is, 4 to 6 hours, for example.
Tell me this then. If I know the shoulder issue is rotator cuff related, is the ibuprofen doing anything? Does that variable add or subtract?
Are you saying does it cause harm, or does it a Band-Aid, or what are you saying?
Exactly. So knowing that it's a rotator cuff injury and not just general soreness.
No, I think you can do it for anything, quite frankly.
All right.
I'm, for intermittent use, I'm frankly a big fan as long as you don't have any contraindications and you take it with food. It's not, not on a prolonged basis, but for muscle or joint soreness that's inhibiting your ability to do things, I think it's okay. You just have to make sure you don't have those medical issues like hypertension or risk of stroke or GI disturbance or ulcers and things like that could put you at risk.
So to go one step further, when I'm trying to get my dog to calm down, I'll smush up the Benadryl or the baby aspirin and put it in pudding or cheese or something like that.
Okay.
Will it have a greater effect on me as a human if I
put it in
smush
cheese?
it up and put it in pudding or something like that, as opposed to just taking
I think
the
it
pill?
will taste much better.
Okay.
Okay. Certainly those medicines, when you crunch them up, they're not meant to be eaten that way, okay?
They're not.
So I would suggest if you want, because you can't swallow a pill, put in a little chocolate pudding and see how that goes for
thank you. Appreciate that.
No problem.
Shane Reardon, our producer,
love it.
great stuff.
And Shane is very handsome this morning, isn't he?
He is.
His new promotional gear.
Yeah,
Love
absolutely. Absolutely. He's got the khakis on. You work at State Farm or something?
The shirt
Hopefully
button
not.
up always.
Hey, don't
Got
start,
the,
Steve.
The
All
flannel,
right.
the flannel shirt. I love it.
Last one, Dr. Cole. This is right up your alley. What are the long-term benefits, risks, post-ACL injuries?
I would say number one risk is recurrence, which is about 5 to 7%.
Re-tear?
Yep, re-tear. Although on our series, we're no worse than 2 or 3% max, quite
Really?
frankly. I mean, if I do 200 ACLs a year, I might see 1 or 1.5 re-tears a year.
Wow.
It's pretty low, thank God. That would be one. I would say loss of extension is another one, and that can happen between 5 and 10% of the time. People always ask, why do you have to wait a month or so to get your ACL reconstructed after an injury? Why can't we just do it right away? And that's because the risk of stiffness is much higher if you rush the surgery. So we usually wait until the motion comes back, swelling goes down. So stiffness is probably another significant risk factor.
Is there a more increased rate for NBA players or professional athletes on the re-tear of an ACL?
We've looked at that. I've actually published on that topic. And the answer is there is a re-tear rate that's probably higher than the regular population, but it's not nearly as high as you would expect. That's what I can tell you.
And you also found out, and we talked about this a number of times on this show, maybe years ago, though, that you're finding that most ACL NBA injuries happen later in the game, which makes sense, right?
Yeah,
Or
that's exactly right. Because if what happens is we test our athletes when they're fresh and not fatigued, and we look for these risk factors, right?
Yeah.
But the irony is when you look at when these injuries occur, it's usually when they have cumulative minutes, and it's in the third or fourth quarter, and when they're long in the minutes, and that probably has a lot to do with fatigue. It absolutely does, because all of these mechanisms that prevent the ACL injury, as they start to break down, all it takes is a nanosecond and something happens and the muscles don't contract or respond appropriately, and boom, all the energy gets transferred to the ACL.
Great stuff. And again, if you want to be involved with our Ask the Doctor segment, go to the homepage on our website, sportsmedicineweekly.com. Click on the link underneath our picture, and you can ask Dr. Cole a question, and we will relay it to him on one of our shows. We're out of time. Many thanks to our producer, Shane Reardon. Our coordinating producer is Teresa Ann Seeger. Also want to thank David Cole for managing the website, our business operations, as well as Samantha Smith from Midwest Orthopedics at Rush. I'm Steve Cashel for Dr. Brian Cole saying so long. Up next here on 670 The Score, it is Inside the Clubhouse with Bruce Levine and Matt Spiegel. Talk with you again next week, only on
670 The Score.